Hello everyone, welcome back to my channel. First of all, I would really apologize for not getting back to your questions, unable to upload the video as I was pretty occupied with my residency and as I'm starting my return of service soon. So the documentation and the accommodations and everything is just so hectic at this point. But now I'll try my best to upload the videos as much as I can. As you all know, I have started a Cmpa series, which means I'm going to study all the good practice and later on I can study the e-learnings, and then it will be helpful to you to just listen to those and find out how you can attempt the ethics questions in the QE1. One thing I would highly recommend you guys is, once you feel that you are very much confident in ethics, then you book your exam, because ethics is one of the major portion. Doesn't matter if you have given the ethics exam last year, doesn't matter if you are giving the exam this year, ethics will always be the top priority to work in Canadian healthcare system. Second thing, when you are working on any kind of interviews, you sometimes really get ethical dilemma questions. It doesn't matter it's an MLPIMG, doesn't matter it's CARMS, doesn't matter it's PRA, whatever the things are, you need to understand the ethical portion, how you can navigate a situation when that's not a clinical situation, but you have to react and you have to approach in a way like a Canadian medical graduate will be doing the same thing. So don't underestimate ethics, don't underestimate the website of Cmpa. They are very important. All my close friends who are preparing for QE1, I always tell them, do not let yourself away from the Cmpa when you are preparing for QE1, because it's very important. It's a very highly asked questions portion in your exam. Then you will not realize until you sit on the day of the exam, and on that chair you will feel, oh, I have learned this, I don't know about this. So that's why I would again repeat, please read Cmpa. If you like my videos, you can just go through it. I will try my best to cover, but I cannot promise before your exams I'm able to finish the whole website. So it's better that you do your own research and do your own homework by reading that. Without wasting any time, I'm going to start the clinical decision making. If I'm going back to this website just to show you what I have already uploaded, those of you who are new to my channel, I have uploaded all these 4 things from the good practice. So how do you go to the good practice? You go to the educations and events and you go on the good practice. You will come to this page. On this page there are 5 things which you have to learn. When you see the topics, you will see these types of topics are coming, and fortunately, unfortunately, I can't tell, but yes, you have to read all of them when you're going for a QE1, because these are very important topics and the questions might come from there. The question will never tell you, oh, it is an ethics question. There is no signpost. But the problem is, when you get the question, the initial 3 lines will look like, oh, there is something going on clinical. But at the end of the question, they will ask you, how would you tackle the situation? How will you navigate this patient? How will you approach this question? So that's kind of a things always comes. Initially, they give you bombarded with the information of clinic, but at the end, they're asking you something ethical. So I have already done these 4. It was in different parts. Some are 4 parts, some are 2 parts, some are 1 part. So if you haven't done those, you can do that, but it doesn't mean that you have to start from anywhere and go anywhere. Just read the parts, but you can start boundaries first and professionalism second, or the cultural safety first and the privacy and confidentiality second. Doesn't matter. Even though the one which I'm reading today, clinical decision making, you can start from here. Okay, so let's get back to our topic. What is clinical decision making? We are talking about decision to be made for the betterment of the patient's health. And we always know that we always do in the favor of what patients want, because that's called the autonomy, right? So clinical decision making, then if the patients want, we choose that, then what's our part? Our part is to navigate them, which is better, which is best, which is not better, which is very poor, and which is going to make your life in danger. So these are all the things we help them in their decision making. We are not making their decisions, we are helping them, because we have enough knowledge about that clinical conditions which the patient is suffering from. understanding decision making to improve diagnostic accuracy. Why we are trying to do that? Because we know what the diagnosis is, we can accurately tell them, we can try to improve their decision makings. Arriving at a diagnosis and clinical decision makings are the complex processes involving multiple steps. It is generally accepted that the clinical reasoning involves two stages: an early stage that involves generating one or more diagnostic hypothesis, that's we usually call differential diagnosis, because we are not sure about the perfect diagnosis, but we are still narrowing down all the differentials which we can think of in this sign and symptoms and the management or investigations options. A subsequent verification stage where the hypotheses are tested and the final diagnosis is confirmed. Definitely when you are coming to the three narrowing down the differentials, you might have a strategy how to go to the finish line and say, oh, this is my first diagnosis, this is my only diagnosis at this point, so I'm going to treat according to that part. The dual process through theory of cognition suggests the two system of thinkings are at play: intuitive, fast, and almost unconscious thinking, often referred to as system 1 thinking, and slower, analytic, and effortful thinking, which is system 2 thinking. Both system 1 and system 2 thinkings are involved in each of the stage of the clinical reasoning, and the complex interplay of the automaticity, unconsciousness, behavioral drift, and cognitive bias and experiences influence sound clinical reasoning. So what we are trying to do is, when we find a sign and symptoms, the patient is in front of us, our first fast thinking process is called the system 1 thinking, and we narrow down it to the differential diagnosis. But the second one is slower, but it's more analytical, and you have to put some efforts on that thinking. That's called system 2 thinking. System 2 thinking is slower because now you are excluding and including the things according to the situation, and that both of these things are very important in the clinical reasoning, because you cannot jump to system 2 thinking once you don't have the system 1 thinking, right? So this is the complexity of the interplay, and that leads us to the clinical reasoning. These are a lot of good practice guides from the clinical decision making. I'm going to expand, and I know this will be a long for the one video, so I will hopefully post 3 or 4 parts of this video, but initially I will probably try to do 1 or 2. So psychology of the cognition. System 1 thinking is intuitive, fast, and almost unconscious. System 1 processes makes a direct association between new information and a similar example restored in the practitioner memory. It is based on the pattern recognition, accumulation of the many automatic response. For example, when an experiencing physician sees a typical skin rash and identify signs and symptoms and recognize a clinical syndrome, they instinctively arrive at the diagnosis of unconscious pattern matching to a clinical template acquired through experience. Arriving at a diagnosis through pattern recognition is quick, often very effective, and usually correct. And they're not doing a lot of efforts, right? That's why we call it very fast system 1 thinking. However, it is prone to interface by cognitive and affective biases as well as attentional drift, decreasing attention paid during the routine practice while using system 1 thinking, and that may occasionally mislead even the most experienced physician. What is happening? The only thing is, if you take a skin rash and you go to a dermatologist know, oh, the patient come from here, there is a lot of things going on here, so probably this is one of them, but there may be a chances that something else is going on, but they don't try to navigate those things in a very complex way, because they always think in a most common day. That's why sometimes misleading is common, but very commonly it is always accurate. System 2 thinking is conscious, analytic, and effortful. System 2 is slower and more cognitively demanding than system 1 thinking. When no match for a given clinical presentation is found in a practitioner memory, or when the situation is ambiguous, the physician employ analytical reasoning, which require a more deliberated methodological approach. I think we can talk about this in a new practicing physician, because in new practicing physician we do not have a lot of experience, so we always talk about system 2 thinking, because everything is very new to us. Everything we're trying to being more analytical, being more reasonable, being more deliberately going there. Medical students and residents make greater use of system 2 thinking as they acquire the knowledge required to guide practice. A healthcare professional gain expertise, knowledge, and experience. System 2 thinking increasingly yield to system 1 thinking, and this allow busy provider to be more efficient and effectively manage heavy workloads. I think the example which I was giving was exactly the same thing, but yes, it's happening, and it's okay. It's okay to start with system 2, but once you have enough experience and you are being more expert in anything, then you can go back to the system 1 thinking and then switch to system 2 if needed. Both approaches to diagnostic reasoning are essential to successful practice of medicine, and both bear their pitfalls. When system 1 thinking is more prone to cognitive and affective biases, system 2 thinking required a sound knowledge base as an anchor. Experienced or expert provider learn to leverage both modes of thinking to call upon the skills inherited to each based on the situation. Strategies to promote sound clinical reasoning should focus on both systems. I'm gonna open this one because they are giving a link of what kind of biases we have while we are doing thinking. So if I'm not mistaken, it's probably one of the human factor. I'm just gonna find it out. Give me a few seconds. And if I have that, yes, so we have this human factor, and if I go back here, we will be reading the cognitive biases here. So I'm not going to read it today, but I'm just going to tell you a little bit about what the biases are, but we're gonna finish this one when we are doing this human factor topic. A healthcare provider mental, emotional, and physical states can interfere with their ability to think, reason, and make decision, analyze problems, plan, communicate decisions, and work in a team. Definitely we all have our own state. We are mentally different from each other, emotionally we are different from each other, and physically we are different from. So that's why we all have the different way of ability of thinking. Generally, according to the dual process, two systems are involved. Healthcare provider use both to arrive to a diagnosis, toggling between them. However, novice means new uses the slower system to approach more often than they have not yet learned all the pattern required to the rapid thinking. On the other hand, experienced physician use system 1 thinking more based on the mental library of the cases. For example, experienced physicians see a typical rash and then they can find out. So this is the one thing. What is the cognitive? They are just giving the same thing which we read just now a few minutes ago. So I'm going to skip that. I'm going to go to the cognitive and effective biases. Biases are what? Distortion of the thinking. And effective biases are intrusions of the physician's prejudice and emotions, may interfere with reasoning and decision making, and sometimes results in inaccurate judgment and ability to reach to the correct diagnosis. So that's one thing. Like biases means even though we are doing it unconsciously, but sometimes they are not giving us the accurate information and they lead us to the misleading kind of a thing. So that's why these are all the kinds of the biases. I'm not going to read it today. It's going to be longer and changing the topics. I'm going to go back and then starting there. Okay, so now we read this one. What is system 1? What is system 2? What is the benefit? What is not the what is the disadvantage? Who use system 2? Who use system 1? And why we are doing this? Because when you give the reason to the patient why you come to this diagnosis, you can tell the reason. That's what the topic says. You have to tell the clinical decision making, why you made this decision on the basis of your clinical experience, on the basis of your knowledge, on the basis of your thinking process. So that's what the one thing is. Being methodological, paying attention, and taking a diagnostic pause. Clinical decision making is functions of complex interaction between system 1 and system 2 thinking in context of personal performance, modify factors like anxiety, fatigue, stress, hunger, etc., and systemic performance, modifying factors like bullying, hierarchy, resource limitations, over reliance and intuitive thinking and automatic, as well as failure to employ cognitive forcing strategy to leverage analytical thinking and minimizing inattention can lead to suboptimal decision making. So what are they talking about? They're talking about how do you pay attention what you are diagnosing, what is your methodology, and how you are taking a diagnostic pause before you say, oh, this is the confirmed diagnosis. Definitely it's a complex process. People are having their personal performance modifications, like we were talking previously, like having their physical, having their emotional, mental, anxiety, fatigue, stress, everything factors depends on that, because that's what they're contributing to your thinking and the systemic stuff. If you do not have resource, then you will say, oh, I'm going to take this out and I'm going to do like something else, right? So that is one of the things for the system related factors, and you have to modify your thinking according to the stuff available on your table right now. Over reliance in an intuitive thinking, which is the first one, and automatic, which is the first one, as well as failure to employ the second one, sometimes give you the leverage of analytical thinking and minimize attentions, and that can lead to some of the clinical decision making. Experienced physicians have knowledge of disease patterns that were learned over time. They recognize the subtle difference between their knowledge of the disease, illness scripted, and a specific presentation of the patient's thirst, the distinguishing between typical and atypical presentation of the disease. The early stage of the diagnosis extract this knowledge from memory. The early stage of the diagnosis extracts this knowledge from the previous memory, because there was another patient came 2 weeks ago with the same presentation. There was a typical features like this. I know what the illness looks like. I think this is the one thing. That's a experienced physician will say. A methodological approach to collecting and evaluating information and a thorough knowledge base of the disease presentation is crucial to successfully arrive at the hypothesis. This can occur only by obtaining sufficient clinical information from the patient's encounter, history, physical investigations to inform and verify the initial gut diagnostic hypothesis. So I'll give you a little bit of example what I'm talking about. Most of you have worked in emergency and urgent cares. Some of you have worked in Canadian healthcare system. Some of you worked back home. So what is happening is, when the first time patients enter into the hospital, there is a one person designated, which we call the triage system, that's seeing the patients first. So patients comes and say, oh, I have epigastric pain from last 2 years. It's on and off, but recently from last 2 days it's 10 out of 10, and I'm having a vomiting, I'm having nausea, and when they check the vitals, the vitals looks perfectly fine, right? So when this little bit of information is read by the physician who is in the emergency, going to take care of this patient in maybe 15 minutes or maybe 15 hours, depending where they work, they're going to have an hypothesis to say, oh, what I'm missing here, vomiting, nausea, epigastric pain, 10 out of 10. Possible patient could be having any kind of obstruction, maybe. That's their one thought is, but they are hemodynamically stable. That means let's the obstruction out. Then they're gonna think something else. Oh, it's just the GERD, maybe, right? So when they make this hypothesis with the GERD and the obstruction, what they're gonna do is they're gonna go to the patient and they're gonna ask the questions which they want to include and exclude in their differentials, because your gut had a diagnostic hypothesis, but now you are going to the patient and you are going to start taking history, you are going to do physical, and you might do some investigations to make sure you are not missing the obstruction, because if you miss the obstruction, that's a problem. But if it's a GERD, oh, you are safe, right? But from that little triage history, you made your gut to tell what could be the diagnosis, differentials, and you go to the patients and you take the history to rule in and rule out your gut diagnostic things. So that's the difference between when someone is experienced and non-experienced. And how do we tell that we are doing this methodological approach? Among the most prevalent cause of diagnostic delay is the physician's failure to capture sufficient information through while taking the history, performing the physical, and ordering investigation and documenting care. When asked to collect information, physician tends to favor fact that confirms their beliefs. Once the initial hypothesis or favored diagnosis is made, physician tends to suppress incongruence and ignore missing data. And being aware of this tendency and taking the time to consciously consider its impact, a process called cognitive forcing may help you avoid cognitive pitfall that can lead to the diagnostic delay. So that's what we are talking about. That's what I just said. When you have an hypothesis, when you see a triage notes, you always try to rule in and rule out rather than thinking something else, like epigastric pain, 10 out of 10, thousands of differentials, pancreatitis, but the patient is not alcoholic, patient is young. What do you think of? Patient doesn't have any history of gallstone, maybe cholelithiasis. There are thousands of diagnoses, but they made a differentials according to the base of their history. What I said in the initial is 2 years history of epigastric pain related to could be GERD because patient never paying attention. Maybe patient took some treatment. Maybe patient has an H. pylori test, or no, patient took any pantoprazole, PPI. We don't know. So that's kind of a things we try to think of, because it's not an acute today's come. If it's today's, then yes, it could be pancreatitis, it could be bowel obstruction. But why we say it's a bowel obstruction? Because it's a nausea and vomiting and 10 out of 10 pain. And when you do the differential, when you do the physical examination, you will probably know what the patient abdomen looks like. It's a surgical abdomen, it's a peritonitis. If it's just the soft non-tender belly, what do you think? It's a distension, non-distension. That's what we are trying to do. So we make our 1, 2, 3 checklist, and we go there and we try to say, oh, this is out because the patient doesn't have this. Oh, this is in because patient have a typical features of this. So these kinds of things we look for. That's why we sometimes miss things. And to avoid those cognitive pitfalls, we need to be more thoroughly, consciously considering the impact what we are doing. Diagnostic delay arises from cognition arise in expert and novice alike. While experts are more likely to overlook incongruence or missing information, they are less likely to make mistake in generating a hypothesis based on their knowledge of the pattern of the disease. Novice, new people, require time to learn the pattern of the illness and are more likely to generate a faulty hypothesis, but are less likely to overlook the data. So the question here is, how do we improve, right? Even though you're a new physician, first day in ER, or you are a physician from 10 years in the same system with the same community, you are saying you will have a different way of approach. In addition, novice may pay more attention to faulty and irrelevant data and hence generate a faulty hypothesis. Consecutively, a multi-pronged strategy is key to minimize the diagnostic delay. A strategy to improve diagnostic accuracy are based on acquiring and retaining knowledge, retrieving that knowledge from your memory, performing sufficient through clinical encounters, employing cognitive forces strategy to leverage system 2 thinking to complement system 1 thinking. These are all the things we can do it. But in an emergency situation, can you apply all of these? Practically, no. Theoretically, yes. So that's why sometimes we say, oh, we went to the emergency, but we never find an answer of your pain. We never find the answer of our symptom, because they just ruled out few of the life-threatening situation and they send you home that your family doctor can figure out what's happening, because you do not have that much of time to spend on one patient. Then there are 10 different patients in the waiting room and someone is having a minor heart attack right now. That's kind of a thinking is very, very important. That's why experienced physicians are able to run the emergency more quickly, because they know what they are looking for and their things are mostly right. Okay, fortunately, unfortunately, I can't tell, but this is the way the strategies works, and that's what this clinical decision making is asking us and telling us to do and what is happening. I'm not judging anything, I'm just telling you the things which we are having way of thinking, being an experienced physician, being a new physician. Even though you talk about a residency, like if you go in a residency, you think, oh, the calcium is like 0.2 low, should I consider this hypocalcemia? Potassium is like 3.3, should I really consider it? Experienced physician will say, oh, it doesn't matter to me. But you, oh, it's 3.3, should I consider it low or no? So that's kind of a thinking comes because they have different experience. You do not have that much of experience as being a resident. Anyways, decision support tools, direct refractive practice, and diagnostic checklists are helpful in acquiring knowledge of typical and atypical presentation of the disease, as well as helping less experienced physicians recognize inconsistent and atypical features. For expert, the aids are more effective when applied in a more methodological verification or second stage of the diagnostic after arriving to the initial hypothesis. So I'm gonna stop this video here. I'm gonna start all the other parts of this guidance in the next video, cognitive forcing and reflective medicine. I hope you like this video. Let me know if you wanna tackle something else in Cmpa before I finish the good practice, because good practice gonna takes me a few months for sure. So the way I'm recording, I feel that. Let me know if you like this video, if you want me to share something else, something different which is not available outside. I have given my QE1, I'm doing my residency. I can help you more thoroughly, but I need to know what you want. Do your little bit of homework and tell me what are the things you want me to do. As guiding an IMG and advocating for your exams and everything. Thank you so much for listening to this video. I will see you in the next video. Thank you. Bye bye.